I would like to thank Dr. Shreya Thatte and Dr. Shah for this wonderful opportunity. कहाँ गया? हाँ, yeah, this one only. So I shall be speaking on post-keratoplasty challenges in cataract surgery. So there are a lot of challenges in these case scenarios because first of all the counseling is quite different and takes a bit of time because these patients might not have that good visual outcome as compared to routine cataract patients. So the chair time, preoperative chair time is more for these challenges. Other challenges which are involved are like IOL power calculation, controlling of the astigmatism, choice of the IOL, and during the surgery endothelial protection. And the post-operative care is a little bit different from a routine cataract surgery. So to begin with, you have to start with the clinical examination of the graft, how it is, the clarity of the graft. A specular microscopy you need to do to see the endothelial cell status, and then you can manage the astigmatism, do a topography, and you can do a selective suture removal to stabilize your K values, regularize the cornea more. And once it is regularized, you have a repeatable topography with you. Then you can go ahead with your IL power calculation and IOL selection. Usually, even for a regular corneal astigmatism, you can plan for a toric IOL. In post DMAC eyes, sometimes you might get away even with a multifocal IOL, but that is strictly limited to a DMAC, post DMAC eye. These patients might have surprises, so it's important for us to examine them just before the surgery, like this guy who was planned for cataract surgery, but when I saw him just before the surgery, I saw that the patient had edema of the graft and KPs and a reactivation of viral keratouveitis. So it's very important that to examine these patients preoperatively, just on the day of surgery also. So you might have few surprises in these patients. Intraoperatively, these patients, of course, the role of endothelial protection, as described by Dr. Sushmita Shah, the use of a double shell technique is very important in these patients to prevent the endothelium. And these patients also have some anterior chamber complexities. The cases are not usually straightforward, like this patient with complicated cataract and posterior synecdoche. These patients might have also peripheral anterior synecdoches also, and the IOP issues are always there. So you have to check on all these levels. Again, this patient, you can see a lot of peripheral synecdoche and a complicated cataract. So IOL expanders, as described by Dr. Share Thate previously, can be useful in these cases also. This is a small clip of phaco in a patient with post-therapeutic keratoplasty. Once you get to have a repeatable topography, you can just do your L ball calculation and start your surgery. I want to highlight that I have made a scleral corneal tunnel to be as far from the graft toe junction as possible, because if you are going clear corneal, just to be a little bit cautious that you not disturb the graft toe junction. In this patient also had peripheral anterior synecdoches, so you have to release them, and using soft shell technique, again you can complete the phacoemulsification in the most routine way. This is another case in which the patient had a penetrating keratoplasty done elsewhere. She was a 20-year-old female who had a penetrating keratoplasty for keratoconus, and she then presented to us with a clear graft but highly irregular astigmatism. So to correct it, we adopted an approach of resuturing combined with phacoemulsification. As you can see, the wires are so distorted. The graft was clear, so we were like, we have to retain this graft. So we started with a scleral corneal tunnel incision, as I said before, and then the cataract surgery was done in protecting the endothelium, and then making a rhexis. As this was a 20-year-old female, the cataract was not very hard, so just by doing irrigation aspiration, we get away with this cataract. And once IOL implantation was done, we injected pilocarpine to bring down the pupil, and then air was injected, and then all the sutures which were present previously were removed, and the graft host junction was partially opened, and a resuturing was started in this patient. The IL power calculation, I forgot to mention that we used standard K for this patient for IL power calculation, and then resuturing was done, which was like combined suturing. in which first 8 interrupted sutures and then 16-bit continuous suture was done, so that a better intraoperative astigmatism correction can be done. So as you can see, the Myers become much better once we regularize the astigmatism. And this kid is under follow up, our follow for last 2 years, and the astigmatism, you can appreciate that the average K which is here is like 45.75, which is pretty much close to our standard K. And even after 2 years, we this kid is doing great. Post-operatively, yes, as I said before, these patients require a closer follow-up as compared to the routine cataract patients, and you might want to hike up the steroids, both topically and systemically, to maintain the graft functionality. Intraocular pressure issues are to be tackled even pre-operative period and post-operative period. Patients who had underwent keratoplasty for viral keratitis, you need to hike up antiviral. You have to give antiviral cover at least 7 days prior to the surgery, and you have to continue it for at least 3 months post surgery. Thank you for your patience.